Okay, thank you. So welcome everybody to the August meeting in public of Sheffield CCG governing body. We'll start with apologies for absence. So I've had apologies from Andrew McGinty and Lisa Phillip, who has actually joined us now. So thank you, Lisa, for taking the time to join us. Apologies from Zach McMurray, our medical director. And Michelle, are you aware of any other apologies that we've... So welcome everybody. Okay.
Terry, I can come in. Sorry, we've had...
Thank you, Jackie.
Apologies from Marion Sloan.
Okay, thank you.
And Alan Windle, but Gary's here on Alan's behalf.
Okay.
Just in terms of the number of absences, I've just checked quorum. So we have got sufficient clinical representatives and lay and exec members to go ahead.
Okay, thank you. So we can declare the meeting as quorate. Before we go on to the next section, which is declarations of interest, I'd just like to welcome Kath Tilney, who has been appointed as our new Associate Director of Corporate Services, and she's in attendance in the meeting today, and also Sandy Buchan, who is our new Director of Commissioning Development. So welcome both of you to the meeting. Both of these members are in attendance today and have notified me of their declarations of interest ahead of the meeting. From those declarations, there is nothing of interest for this meeting. So to go on to our usual membership, has anybody got any substantive declaration of interest in any of the items on today's agenda? Okay, thank you. So I'm just going to hand over to Jackie Mills. Now, Jackie, have we had any members of the public putting questions to today's governing body?
No, we haven't received any questions.
Thank you very much. Okay, so it's over to me for my opening remarks. I'd just like to kind of reflect back how busy we've been as a CCG over the last few months working through our response to COVID. And also to reflect that last week, NHS England formally moved from the phase 4, level 4 pandemic response into a level 3 pandemic response. And that's largely around 3 key things. One of them is the restoration of clinical services. There is a need for us to consider how we reset some of those services to work in a new way that is reflective of the pandemic. And there's also something around us making sure that we begin to catch up on some of the work as an NHS that has been paused. So there's something there around our recovery and making sure that patients who have been waiting for treatment and services that we need to get on and deliver are something that we make our priority. I think that's going to pose us with the CCG with a number of challenges. However, we have learned an awful lot from how we've worked through COVID, which will be really beneficial to us moving forward. Some of those items are going to be picked up in today's agenda, particularly our response to the COVID pandemic and some of the impacts that that's had on equality. So we'll build those into the agenda a little later, and I won't go into detail on those things now. So we can now move on to the first substantive item, so paper A in your pack, which is approval of the minutes of the previous governing body meeting. So I'd like to start with looking at pages 1 and 2, and if members of the governing body can let me know if there's any amendments or any inaccuracies that we need to flag up on. So pages 1 and 2, 3 and 4, 5 and 6, pages 7 and 8, pages 9 and 10, 11 and 12, 13 and 14, and finally page 15. Okay, so we've not had any amendments or any further clarification needed of those minutes. So governing body will be accepting those minutes as a true and accurate reflection of the last minute. Thank you. So that moves us on now to the matters arising and actions from our last meeting. So I'd like to start with minute item 122/19. And this was around the public question around vacancies. We received an update at the last governing body regarding this. I'm wondering, Brian, if you could give us an update on where we are with that at this stage.
So the information, Chair, in relation to the workforce group of the Accountable Care Partnership is only now starting to reconvene. So the issues around agency spend and vacancy will be picked up through that work. So I will report at a future governing body. It was suspended or postponed during the COVID work.
Thank you, Brian. I'll move us on to item 1320, which was the item about how we facilitate intelligence requests from practices and the appropriateness of collecting that information to be fed back to the Yorkshire Ambulance Service. Again, at the last meeting, we received an update that this work was underway. Could you update us on that, please?
Yep, work still underway, Chair, but in light of the other requests that were within primary care, that data has not been taken forward. But now that we are moving back into a semi-level state, we will start exploring that information in further detail with practices and with our ambulance service as well.
Okay, thank you. Item 3520, the governing body assurance framework, is on today's agenda. So we will pick that up in the course of discussion this afternoon. The operational plan, so this is item 3620, our operational plan, including the commissioning intentions. Could we just have an update on where that is? I'm going to ask Lucy or Brian if you can update us on that, given Nikki has joined PCS as another organisation and isn't with us here today as the responsible director.
That work is still ongoing. We have a version of revised set of commissioning intentions and priorities, which we will be discussing in private today. Part of the intention on that is to make sure that it is in a understandable and readable format. So once we get those signed off, we will be producing those in a easy read format. Thank
you, Brian. The next item was item 7020, which was regarding an email from Healthwatch Sheffield. I have met with the chair and chief executive of Healthwatch, and we can now recommend that item for closure. Item 7520, a question from the member of the public, has been completed. We will recommend that for closure. Item 7820, feedback from lay members. I've got Professor Gamsu. So Mark, are you able to give us an update on that item, please?
Yeah, I'm not sure. I've spoken to both Lucy and to Judy about this, albeit late in the day. I spoke to Judy today. I'm not sure that accurately reflects what we said we do, which was to share with Healthwatch through the chair some of the background papers to do with the work we've been doing on equalities, which is on the agenda. Again, I think we could have shared. It's on the agenda now, and I know that Judy's had that information shared with her. I mean, we should probably have shared that a bit earlier.
Okay, so we'll pick that up on today's agenda item. And Judy, if you could indicate to us whether there's any further information you need following the discussion on the agenda. If there isn't, we'll recommend that item for closure. If there's further work for us to pick up on, then we'll add that down as a new item to pick up on at the next public meeting as a matter arising. Are you happy with that approach, Mark and Judy?
Well, yes, I think there are some issues around that on the agenda today. I think I would just ask if we could have that sort of information earlier. That would be very helpful.
Okay, thank you. We'll take note of that, Judy, and make sure that those communications are more timely for future. Item 79.20, the adoption of the audited accounts. I have written to Jackie and the finance team, and I'm aware that Zach McMurray has written to the medicines management team to offer our thanks on behalf of governing body. So both of those items are closed. The performance, quality and outcomes report, which is item 82.20. The work on those points there has been completed, and that is also recommended for closure. Item 83.20, which was to seek clarity on the routes for dentistry support in care homes, was an item there for Alan Windle. Gary, you're attending on behalf of Alan today. Is there any further update that we have on that item at this stage?
I'm sorry, Terry, no, I don't have an update on that. I can obviously ask and get back to you. Okay,
thank you. We'll make sure that we pick that one up in our next meeting. Thank you. So we'll, Jackie.
Just to know, it was due to come back in September, so I think that's why it's not.
Okay, perfect. So we'll bring that one back into our September meeting. A further item under 83.20 was to send communication to Dr. Sarah Mitchell to congratulate her on behalf of receiving the Yvonne Carter Award for Outstanding Early Career Researcher. That letter has been sent out, so we recommend that item for closure. And then the final item under matters arising 84.20 is around our safeguarding assurance report. So the first part of that was to raise the concerns from GPs around midwives not visiting the premises. Alan has fed back that discussions are ongoing on this item, and I recommend that we bring that back to September's meeting for further clarity. And the second part of that item was to look at how we include an oversight of the safeguarding board in our quality reporting to QAC. So if I could ask Mandy Forrest as chair of QAC, if you could just give us an oversight of where this work is at so far.
Yes, it'll be discussed at the next QAC, which is at the end of this month. So we're scheduled to report back here in September.
Thank you. So we will, if we can add a September deadline on that. There is one already, but if we can make sure we bring that back as a substantive agenda item with the safeguarding assurance and the quality assurance committee report for September, that would be helpful. Thank you. Okay, are there any matters that are arising that any members would like to pick up on that aren't on the list today, or any further detail on any of the existing items? Okay, thank you. So I'll now move us on to our next item, which is a patient story. So for those members of the public that have not observed a governing body before, we generally like to start our meetings with a real story from members of the public. And this month we've got a video that's been produced by some of our patients and some of the people in Sheffield who use services. So Gary, I have you down for introducing that item. So over to you, please.
Okay, thank you. So today's patient experience video is not about one patient, but about the common experiences of the BAME community during COVID, and it's been described by Shahida. Shahida works for Faith Star, which is a leading BAME community organisation in the city, and she also chairs the city's BAME community public health group. The video highlights just some of the experience that the BAME communities have gone through and how they've been disproportionately affected by COVID in many ways, including the health, mortality, and socially and economically as well. I think this video complements item G, which is the equality report further down the agenda, and hopefully will help set the tone for the meeting today to inform our discussions, debates and decisions. So if hopefully the technology will work, I'll hand over to Lucy.
Right on cue, Gary, it isn't. So can I suggest that I try and get it working and maybe play it just before the equality report? Terry says, I think you need to enable sharing. I don't know if you need to make me host again. Sorry.
Screen sharing has now been enabled, Lucy, so you should be able to play that video. If there are any technology blips, Lucy, we can move on to the next item for trying to keep the meeting timely, and we can bring this back, particularly as it's quite poignant to some of the equalities discussion we'll be having later. So
I think I'd suggest that. I can't.
Okay,
yeah.
so we'll hold that item to a little bit later and move on to the next part of the agenda. So we now move on to our papers for approval. The first paper for approval on governing body today is the Standards of Business Conduct and Conflict of Interest Policy and Procedure. And so I'm going to hand over to Jackie Mills for this item, please.
Okay, thank you, Terry. So just to note, this is an updated policy, and the updated policy was circulated to members in the noting pack, and it has track changes on so members can see what changes have been made. The policy was updated in line with some recommendations from our internal auditors when they reviewed the policy last year, and it has been reviewed by the Audit and Integrated Governance Committee at its meeting in March, and the committee are recommending it to the governing body for approval. And just finally, I just wanted to note that the policy does require that all governing body members understand and commit to the legal and regulatory framework in which we all operate. And so the proposal is that, subject to approval of this policy today, we will send out a statement and ask governing body members to sign and return that. I think that's all I want to say in terms of this item.
Thank you, Jackie. So before we approve this item as a governing body, I'd just like to invite members of governing body with any questions or any comments on this paper to come forward now. So Kath Tilney, if you'd like to come in, please.
It's just a small point, but I think the changes in the structure will impact one of the sections. So it's whether we can make those small changes or would we need to bring that back for approval.
Okay, I think given they're minor and this has all been through an existing process, I'd suggest that we pick that up at the next review, because we review them on an annual basis. I don't think it will substantially change what we need to do.
Okay.
Okay, thank you, Kath. Thank you, Jackie. Are there any other questions or any other comments on this item from any members of the governing body? Okay, so I think we are now in a position to approve this paper. So if you can indicate with your virtual hands up, if you are happy to accept this paper, either with a tick or a thumbs up, we will approve that. Okay, so I'm seeing a majority on my screen there. So thank you, Jackie, that first paper is approved. The next substantive paper for approval is the NHS Sheffield CCG Governing Body Assurance Framework Refresh, which is a very important document in terms of how we as a CCG, and in particular we as a governing body, assure ourselves that our organisation is doing what it set out to do. So I'm going to hand back over to Jackie to update us on this item.
Yeah, thank you. It's a helpful reminder of what the document is designed to do. I think we should note that the impact of COVID has had an impact on the nature of some of the risks that we described when we approved the framework for 2021. And these changes to the risks have been captured in the detailed sheets that again was circulated in the noting pack for members. I should note that due to the capacity constraints in terms of responding to the COVID crisis, this first review of the year hasn't followed the normal process. So we normally have a process of risk owners review, senior management team review, audit and integrated governance committee review, and then finally to governing body. We've had to shortcut that process for the first review, but we will endeavour to return to a normal process for the next review. In terms of the summary, I just wanted to highlight that one of the risks in the framework has reduced in score, but 4 of the risks have increased in score. And one risk has been escalated to a critical risk, and that's in relation to the financial framework and the challenges that ourselves and partner organisations may face, and the impact that that may have on our ability to invest in the priorities that we agreed. Members will remember that back through January, February, March, we were setting out our plan and what our intentions were and where our investments may sit. I think the changes to the financial framework, which I'll highlight in more detail when I cover the financial report, has clearly had an impact on our ability to make progress on a number of those. And it's for that reason that I've raised that risk to a critical risk. We clearly, as we work through the revised financial arrangements, we'll be looking at what progress we can make on a number of those. So we should be able to give an update to governing body at the next review. And then finally, just in terms of the description of the strategic objectives, so we have proposed some slight amendments to the strategic objective 5 in the report. In terms of our workforce, the revised wording that we're now proposing is to be a caring employer that values diversity and maximises the potential of our people. So we are asking for approval to change that strategic objective. So I'm happy to take any questions because I'm aware there's quite a lot of information contained in this report.
Okay, thank you, Jackie. So we have a hand up from Mandy Forrest. So Mandy, if you'd like to speak, please.
Oh, hi, Jackie. Can I just check about the increasing the risk around the finance to critical? Have other CCGs done that? And I know you're going to be discussing it more later on the agenda, but my understanding was the government were going to support whatever costs there were to COVID. So I just want to check that, and I want to check what other CCGs are doing. Are we in line?
I must admit, I'm not aware of what other CCGs have done, but I can certainly check that out. In terms of the reassurances provided by the government and NHS England and Improvement, that's been about responses to the COVID crisis primarily, and also in terms of necessary expenditure already incurred. They did put a pause on discretionary new investments through this period. And obviously, the diversion of that resourcing into COVID response has meant that in some instances, we may not be able to make progress on some of the things that we might want to make investments in. I should note that in other ways, it's accelerated some of the changes that we wanted. So things that we may have chosen to invest in may no longer be our priorities. But I think it is fair to say it will have distorted our medium-term investments. Can what other CCGs have done, and I can report that back to the next meeting.
Thank you, Jackie. Michelle is with us today, taking the minutes of the governing body. Michelle, could you add that on to the matters arising so that we can bring that back for discussion at our next public meeting? I'd like to bring in Judy. Thank you, Michelle. Like to bring in Judy Robinson, please.
Thank you. I want to pick up a particular point in 2.3. I see what you're trying to do, and I think the aim of independence, self-care and education is good, but I'm concerned that the doing things too quickly and not engaging people in the depth that we need to do means that the aim and the method may be rather contradictory. So I wonder if could be a little reflection on that, please.
Yeah, we probably will pick that up again in the future papers that we're going to discuss as well.
Do you mean about spending more time doing it, having a lengthier process?
Yeah.
Thank you.
Okay, thank you. Brian Hughes, please.
Thank you, Chair. I just want to support what Jackie's saying and your introduction around the importance of this document and the importance of this document at this time. So Jackie's outlined a process that has been fraught with difficulty whilst we experienced and lived through COVID, not least the financial position and the uncertainty about that financial position. So I think this document, where it was important before, becomes even equally, if not more important, as we move forward and as we start to look at what we do in a world that will probably be living with COVID for a significant period of time. So those priorities and those actions and the risks that we've got identified in there, I think are really important for this governing body to see this as a live document that, as Jackie outlined, as we lived through February and March, we were doing something. We then had to adapt quite quickly in this reflection. And as we move to Q2 and the next iteration of this, we will see how the sands and the world is shifting in terms of the priorities and some of the risks that we've got as an organisation and as we face as a city.
Thank you, Brian. Leslie Smith, please.
I think it was just to highlight that all of the points that we've discussed are related. So from the financial framework to the listening exercise, to then thinking about going forward our commissioning intentions, what we might want to do in relation to the differential impact that COVID's had on communities and on health inequalities and health outcomes. Actually, that's where we'll start. We may do the listening, but start to become stymied in terms of the flexibility that we've got over our investments and priorities. And that's where it will get really tricky and challenging for us.
I was going to say thank you. So I thank you for the update, Leslie, but potentially the trickiness and the challenge is less welcome. But yeah. I think we all recognise the complex situation that we are now in following the first wave of coronavirus. Anthea Morris, please.
Just a quick one from me. I'm Anthea Morris. I'm the lay member for governance. I do agree with Leslie and Brian of what they're saying, and Jackie, about how we now sort of integrate this. I think COVID is around for a while now, and it is going to become part of business as usual. And integrating that into our risks. I mean, for me, when I looked at the risks, I thought, oh gosh, they're all a bit low. Actually, it's not how I feel we are. But I think also it's also about not jumping to a higher state of alert than we are. We need to understand what it does mean for us going forward. So I think looking at this document, keeping it live and is really important as we go forward over the next couple of weeks and understand what a second phase may or may not look like.
Thank you, Anthea. Are there any further comments or questions for Jackie? Okay, so I've one question, which is around the amended wording around we will be a caring employer, and I'm just wondering, Leslie, whether you've a few words on how that objective in the GBAF meets with the NHS People Plan, which was published very recently. I think it's more for assurance for governing body, because I think the wording in the GBAF does meet the essence of what the People Plan is around, but I'm wondering whether there is a bit of a link there that we can bring today.
Yes, absolutely, there is a link. So I was going to highlight later in the agenda the publication of the People Plan and really thinking about the concept of caring and compassionate employer and the branding of we are the NHS and developing that spirit. I think that reflects quite closely with what we've been doing in the CCG around over the last 12 months, being that caring, compassionate employer. And we are the CCG, one team, or even wider than CCG, one Sheffield, one city, one NHS, and one care system too, of course. So I think it chimes really closely.
Okay, thank you, Leslie. So the paper is for consideration, and I think we've given the paper due consideration in our discussion. And the recommendation to governing body today is to note and comment the review of the GBAF refresh as it is at the end of July. And we've noted the change in risk score and also noted the amended wordings. We've noted the review objectives in light of the COVID-19 pandemic, and we will amend the minor change to objective 5. And we've also being asked to note the proposed review of risk owners in light of the CCG's restructure at executive level. So again, if governing body can indicate their approval of this paper to me, either with your hand up physically or through a digital hand up. Okay, thank you. So Jackie, this paper has been approved. Thank you. So now going to move us over to item 10 on the agenda, paper E in your noting packs. This is another paper for approval and is regarding a sponsorship approval for a value of over £5,000. So I'm going to hand over to Gary Barnfield, please.
Thanks, Terry. So this paper details the offer that we've received from AstraZeneca around supporting the delivery of a service to practices aimed at increasing access to diabetic services for South Asian communities. It's based on an initiative that was run in Glasgow over a number of years called the MELTS initiative, which is the Minority Ethnic Long-Term Medication Service, which received good reviews and good support. The proposal has been supported by our secondary care diabetologists, our CCG clinical lead GP for diabetes, and the MOT lead for diabetes as well. We discussed it at the area prescribing group, and although there was some nervousness, as there always is, around pharma involvement in terms of sponsorship, there were no major concerns from a clinical perspective or in terms of what the recommendations would be. As you've already said, Terry, because it's over £5,000, our governance means it needs to come here to be signed off by governing body, which is obviously why it's here and I'm here. At which point I think I'll hand over for questions.
Okay, so are there any questions for Gary, please? So Nikki Bates.
I don't feel very comfortable in having this kind of sponsorship from drug companies. Really, our practice has avoided any drug company sponsorship for 25-30 years, and I don't feel comfortable in seeing it within the CCG. If this is a good idea, then we should be funding it ourselves and not through drug company sponsorship, as far as I'm aware.
Okay, thank you, Nikki. Lisa Phillip, please.
I think I share the same concerns as Nikki. It's just, I think the sponsorship by a pharmaceutical company. I just wondered about any reporting at the end of the trial or the project. I wondered whether, any reports would be reviewed by the medical team responsible before AstraZeneca publish anything, just for, transparency and just to make sure there's no bias.
Yes, the data, any data that's produced from this, if we were to go ahead with this, would remain under the CCG's ownership. So we would have first say on what happens with that data, and if there was any publication, we'd be able to veto it if we weren't happy.
Okay, Mark Gamsu, please.
Yeah, thanks. I had the same question as Nikki, really, which is if it's a good, if the project's a good one, why aren't we as a CCG funding it? I mean, it's a lot of money. And I suppose it just sort of raised a further question, which is, what are the mechanisms that we have inside the CCG to make this sort of relatively small funding available to innovation?
Okay, I'm not sure whether you'll be able to answer the bit about the funding, Gary, but if you can, this is a good opportunity to do so. Otherwise, I'm just wondering whether Jackie may be able to shed some light on that for us.
Yeah, is it worth me coming in? So obviously we've just approved the revised sponsorship policy. So it does allow for, if we have the right safeguards in place, that we can have the option of using such sponsorship. So it's a judgment call for people here. The pharmaceutical industry have their own standards that they need to adhere to. So we've got assurances that that would be in place. In terms of, it is always an option to, in normal circumstances, to look at prioritising our own resources. Clearly, with the framework I've just alluded to, and we'll go to in more detail, we've got limited scope at the moment to identify discretionary investments. It's a judgment of what the governing body feel comfortable with, and if the consensus is that we are comfortable with the sponsorship by the pharmaceutical company, at the moment I think we wouldn't be able to progress it in the short term, but that's not to say that we can't come back to it once we're clear about the financial framework. Okay,
thank you. Leigh Sorsbie, please.
Hi, yes, I'm Leigh Sorsbie, GP on the, representing Citywide. It's a tricky one, this, isn't it? Because I think we're all culturally quite averse and quite suspicious of pharmaceutical involvement in particularly in primary care medicine. On the other hand, we are looking at a significant health issue that's affecting a population that really do suffer from the side effects and the long-term effects of diabetes. So, and I'm struggling a little bit because the GP head on me is wanting to find out, well, what were the outcomes of the previous study that's been done that it's based on? And because part of that is measuring up the benefits against the risks that we feel in challenging our anti-pharmaceutical culture. But I understand that this has already been looked at by our diabetes lead, so you don't want to sort of tread on toes. But I think given that we do have some concerns and some unease, it would be really, really helpful for us to understand a little bit more about what the perceived benefits would be, because just looking at the proposal, actually we do tend to do this sort of stuff already within primary care. So I'm assuming there must be some added benefit to this that we haven't been made aware of. So I wonder whether it'd be possible to get a bit more information and then perhaps bring it back.
Okay, thank you, Leigh. Gary, I agree with Leigh's stance there, and also just picking up on Jackie's point around the appropriate safeguards. And looking through the document, it does describe the governance, it does describe some of those arrangements. But just coming back to Leigh's point about the anticipated benefit, I'm just wondering if there's anything verbally you can update us on at this stage.
The Glasgow study did show, this is from memory, but the Glasgow study showed increased uptake from that community and improvement in HbA1c levels and other diabetes checks. I'm not sure I could say any more than that without the paper in front of me, but there was evidence of benefit.
Okay.
I do understand people's concerns around this as well.
Okay, thank you, Gary. Mandy Forrest, please.
I think my question's more general. If we've just agreed a policy that allows for sponsorship, I'm now unclear at kind of what's our threshold for that. Or are we always going to come down to what we feel is a judgment about each case rather than a financial threshold? So I'd just like to pose that question. I genuinely don't know what we should do about this, and I would bow to the clinical view on this.
Okay, thank you, Mandy. Back to Leigh Sorsbie, please.
Yeah, sorry. Again, don't want to get too much into the details of it, but I'd be really interested in what the original baseline was in Glasgow and what the perceived benefits were, because it may be different in Sheffield. Again, this may already have been looked at by Jenny Stevenson, so I don't want to tread on toes, but I think if we want to make a decision, it has to be an informed one. I also do support what Mandy's saying as well, in that if we have got a policy, maybe we need to stick to it, but because it does feel quite countercultural to us probably as clinicians. I just wonder whether we might need a little bit more information.
Thank you, Leigh. Kath Tilney, please.
Just a question around there's not an equality impacts assessment within the document. So just wondering whether that would be a useful thing to have, recognising we're talking about one language and there may be other languages.
Yeah, you're absolutely right, Kath. We would need to do an equality and equality impact assessment. And one of our concerns that we right at the start was the fact that there is the pharmacist that is involved can speak Urdu, but obviously there are a lot more dialects than Urdu for South Asian communities. We haven't done one at this stage because I think this is the first stage of, are we going to accept the sponsorship, and if we are, then we'll work up the full detailed proposal. So that's why it's not been done already.
Mark Gamsu, please.
Right, okay, we're spending a lot of time talking about a tiny amount of money here. And I think personally, this is more about the principle and what are we getting ourselves into than it is about this particular project. I don't actually agree that it's a clinical decision. I don't think, or it's a clinical advice should take priority. The issue for me is that because we shouldn't be discussing here whether we think a project is clinically effective or not. I don't think that's what governing body should do. What we're looking at is, in this case, is our relationship between private sector funding that's got a conflict of interest in that funding, and coming into the city or us, providing a route in for that, where there's clearly a potential for a significant conflict of interest. That's what we're concerned about, is the mechanism. From my point of view, that's our concern. So actually knowing whether it's constructed correctly in research terms or what previous findings were, I have to disagree with people on that. I think for me, I suppose I've got two questions. One is, if we were to delay making the decision now, would that affect the timing and the impact of the project? Because as Leigh says, actually what they're focusing on is a very important area. So the bit for me is if we were to delay it to the next governing body for a bit more information, would that affect the project? I suppose the other thing I'm sort of inching towards as well is I'm sort of thinking, could we say, well, okay, we've got a fairly good grip on this, therefore we agree it, but we actually use the experience of discussing this, because this is why I think we're spending so long talking about it, because it's fairly unusual, to go away and do some more thinking about how we handle future discussions around these sponsorships. If any of that makes sense, Terry.
Yeah, thank you, Mark. I think you've pointed out quite well that there's two discussions really here. One of them is about the clinical effectiveness, and my understanding from reading the paper is that those things have been looked at by our medicines management colleagues, and they would only bring that forward if we're in agreement with that. But the second question feels more of a question around our ethics as a governing body. And I think that's the nub of the decision that we're struggling with at the moment. So thank you for raising that point. Jackie Mills, please.
Yeah, I was just going to make a similar point to Mark. The reason for having a policy that says for anything over 5,000, that would come to governing bodies exactly so we can have a discussion about reputation, about governance, and about potential risks and benefits. So the policy requires those considerations to be made by governing body for exactly these reasons. And I think Mark's suggestion about focusing on those issues is the thing that as a governing body we should be making a decision on. I think what's our approach, what's our stance in terms of these things is probably a helpful one to have and bring back to the meeting. I don't know though that Gary, is the point about the timing of the decision, you probably can pick that one up.
Yeah, I mean, if we don't approve this today, then clearly it will delay it, you know, taking this forward. But I do think we need to spend some time thinking about our position in terms of pharmaceutical sponsorship, because we're probably all slightly uneasy about that, and I think we need to be clear, if we are doing this, what that means.
Okay, thank you. I think the sense that I'm getting at the moment is governing body feel uncomfortable with making this approval at this stage. And what I'm going to suggest is we take the discussion offline and we work out, you know, kind of what is our ethical position as a governing body, and then revisit this paper in September. Obviously, you know, that doesn't give us an approval here, Gary, but are you happy with that approach?
Yes, that's fine. Yeah.
Okay, thank you. I won't take any new points on this item. And those of you that have got points on that, please come and have those discussions outside of governing body with us. Thank you. So I'll now move us on to the next section of governing body, which is a suite of papers for consideration. The first part of it looks at our response to COVID as a CCG, and then moves on to talking about the impact on different equalities that's had. So Lucy, this would seem an opportune moment to bring the video. Are you in a position where you're able to do that for us?
I think so. Let's have a look.
Okay, so we'll move on to our patient story. Thank you.
Yeah. Fingers crossed. Can people see that?
So this is really complex picture. It's not a straightforward set of circumstances for everybody. Some of our BAME communities, particularly in Sheffield, are more vulnerable than others. And that kind of is reflected in the national picture as well. So Bangladeshi men, Pakistani men, African Caribbean men over the age of 65. There's a lot of worry around sort of that age group and those three particular demographics. Quite a bit of concern about supporting those. And then particularly with people that have got underlying health conditions, respiratory illnesses, hypertension, diabetes, obesity, the kind of normal standard things that come up, but particularly for whatever reason, particularly around structural inequality and poverty and all of those types of issues that affect BAME communities more so, is then exacerbated and compounded by COVID-19. So mental health is a key issue, particularly in terms of isolation, getting access to support in a timely manner. That's been quite, and especially for young people, feeling quite isolated, and that kind of digital divide between those young people that have access to the appropriate digital equipment that can enable them to get on with their education and those that don't. Bereavement has been quite a big issue for members of the BAME community, well, all communities really, but particularly BAME communities, where from a social perspective, the celebrating of a person's life or marking that particular life event is done in a very social way. So traditionally what happens within BAME communities, if somebody falls ill or somebody passes away, the community gather round that individual or gather round that family. And obviously with COVID-19, communities have not been able to do that. So from a mental health perspective and a bereavement perspective, that issue is really, really being compounded. So we know there's a bottleneck coming to that. So there's been a lot of kind of bereavement support that's been happening over the phone, but it's not the same. And that's having a huge mental toll on BAME communities, as it is all communities, but particularly because those types of life events, particularly for BAME communities, is something that they mark together. And that has had a significant impact. So those who are medically vulnerable are at a much higher increase because they're from BAME communities and because they may be in extended families. They don't necessarily have the flexibility of space to go somewhere else. And so what you might have is a situation of, for example, if you've got a multi-generational family living together, you know, younger people might only suffer mild symptoms, go about kind of living their everyday life, but actually they're not the ones that are most at risk. It's who they bring it back to. So when the feedback that we're getting from BAME communities is we've really, really got to do more in terms of the communication messages. And that's not just about interpreting. You know, one of the feedbacks that we get is, okay, you might get a set of leaflets interpreted, but you've got to understand that some of those first generation BAME communities might not be able to read in their first language. So yes, you've spent all this money and you've got some leaflets translated, but is that necessarily the most appropriate way? Actually, what is more appropriate is that face-to-face support, that telephone support, that having somebody who speaks your language, who can, you know, help guide you and navigate you through some of the system. And I think one of the things that we have to shift away from as a city is this kind of one size fits all. Different communities are going to need us to really, really understand them and take a nuanced approach to the kind of support. And if we're talking about kind of how we're going to do commissioning differently and what we're going to commission differently, I think that starts by listening to the lived experience that people are going through and very much embedding our response in a way that reflects what they need as opposed to what we think they need. And that's where I think we'll make the biggest impact.
Okay, so quite a thought-provoking video. Lots of issues coming up in that around pre-existing structural inequality, how the pandemic has really exacerbated those things and shone a light on them. For me, I've picked up some important things there that, you know, there's a difference between language and cultural sensitivity, and that needs to play into how we think about our commissioning of services in the future. I think another thing that really came through for me on that video was the diversity of communities and recognizing that diversity so that we can do things in different ways rather than a one-size-fits-all approach. So for me, there's lots of food for thought and lots of appropriate challenge in that video. And before we move on to our next items, I'm just wondering if there are any further reflections on that from members of governing body. Mark, please.
I would declare an interest here as a trustee of Dharma Wellbeing. I think the point that she's making around the importance of relationships and trusted people from communities being an important part of connection is one of the things that, you know, it reinforces that we know we've got to do more work on. We've certainly not is our relationship with key infrastructure community organisations in the city. You know, so organisations not just like Dharma Wellbeing, but you know, like Zest and SOAR, and Manor and Castle Development Trust. We've got a number of them in place who've actually responded very well. They're not just working; they're working in some of the parts of the city with very high numbers of people from minority ethnic communities, but also in other, you know, white working class parts of the city, like Manor and Castle. And it's important, as you know, that, you know, one of the big lessons that keeps coming back out is we must recognise that. And actually, a lot of those people who do that relational stuff are volunteers from those communities who are in touch with people. And there's a message there for us, I think.
Thank you, Mark. Leigh Sorsbie, please.
Yes, just to build on what Mark said as well, I was thinking the same thing, you know, the importance of actually having people within the own community to be the ones who can reach out and educate and support and all the rest. And I'm just mindful of one of the papers, I think it was one of the papers for noting, I think was it one of the ICS reports, reporting on how the COVID crisis has impacted on the voluntary sector. So these very organisations that we need have actually been decimated, really. You know, they've had up to 50% reduction in income, people being laid off, people being furloughed. So we've really got to be mindful of that, the context that we're facing when we're thinking about how we're reaching and supporting these different communities.
Thank you. Amir Afzal, please.
Yeah, hi, Amir Afzal. Can you hear me all right?
Yes.
Because I'm having huge issues.
So I can hear you, and I can see some heads nodding on my screen, so your audio is working. Or perhaps it has stopped working. Amir, are you still with us there on the line? Okay, so it seems that we have an audio problem after what appeared to be quite a good start for you. So are there any further comments or reflections from members of governing body on the video? Okay, Lucy and Gary, would you be able to pass the thanks of governing body on for what was, you know, for me, a really detailed and very well articulated and considered a piece of information back to governing body. And certainly I think we would like to see more of these things out of governing body in the future.
I'm sure we will.
Yeah, we'll pass that on. So thank you. I know Gary did an excellent job of introducing Shahida at the start, but I know we had technical problems. So just to remind people, actually, she's the Chief Officer of Faith Star, who are a really great community organisation in Sheffield. And she also chairs a community group, which is held by the ACP, which is engaging and listening to BAME communities. And they've actually got representation from 30 BAME community groups, and they meet weekly. And it's a really useful, powerful group. And she's doing a great job, and I will pass on the thanks. Thank you.
Okay, thank you, Lucy. I will move us on to the next item then on this afternoon's agenda. So item 11, paper F, which is the CCG response to the COVID-19 pandemic. So back over to Lucy, please.
Yeah, thanks, Terry. I'm Lucy Ettridge, Deputy Director of Communications, Engagement and Equality for the CCG. If governing body members remember, in June, you asked for more information on the CCG's COVID response, or our response to COVID. So we brought that back today in a form of an infographic. We've actually shared this before on social media, but it's been updated for governing body today. And actually it's been updated since, because there's quite a quick turnaround of statistics. And the infographic is really a summary of some of the work that we've done since March. So I'll take you through some of the key information. So we've actually tested nearly 2,700 GPs, primary care staff, community care staff, social care staff, and CCG staff. We've swabbed them for COVID. We've also done nearly 2,500 antibody tests in quite a short period. I think that's about the last 6 weeks. Polls, which is our in-house prescription ordering service, have taken 62,000 calls. We're a small team, and they've been really busy, and they've been doing a great job, and a lot of them are still working in 722. We've distributed or provided 200,000 pieces of PPE equipment, and we've delivered hundreds of laptops, I think 700 laptops to practice staff and staff. So our IT team have actually done a sterling job, particularly in the beginning, where we prioritised getting kit to primary care, and more recently in the last 4 months to our staff. And now all our staff who need one actually have a laptop and access to the network remotely. So we've just been at that today for your reflections, and hopefully you can appreciate all the great work that staff from across the CCG have been doing. And really to ask if there's any other information that you'd like provided on sort of COVID response.
Okay, thank you, Lucy. Reflection from me on the format of the paper. I found the infographic really helpful. It's something that, you know, was very easy to digest the information. And some of the figures on there are quite outstanding, really. You know, the level of work that our CCG teams have undertaken is a testament really to their hard work, and certainly will have made a difference to healthcare professionals and patients across our city. So I think the paper for me was a really, really good one. So thank you for presenting it in that format. So I'll hand over to Mandy Forrest, please, for questions and comments.
Hi, I think it's really helpful, Lucy. Thanks ever so much. And I'm glad it is being shared on social media, particularly the bit about, you know, all the practices remain open, because I think there are people out there who are worried that they can't see a GP, or at least have a consultation with a GP, whether that's online or over the phone. So the more we can do to get across that message, I think that's really good. We've spoken quite a lot, haven't we, over the last few months about our worries that people aren't coming forward when they might have a health need to come forward. So if we can really push that message. And then the only other thing I just wanted to check, the swab tests made available to voluntary sector staff. I didn't realise that. Can you give me a little bit more detail about that? I'm interested to know. Thank you.
I'm sorry, I don't have the detail on the organisations that were eligible, but I can get that for you from the team and email it round to members, if that's okay.
Yeah, that'd be really useful, because I mean, I think there's over 3,000 voluntary organisations in the city. So it would be helpful to know the criteria for that.
Yeah, I think it was offered more recently as the capacity was increased. Sort of demand maybe in primary care declined, they opened it to more organisations, but I'll find out who and how many and share it. Yeah.
Thank you.
Okay. Thank you, Lucy. Over to Brian, please.
Thank you. Lucy knows I love a good infographic, and I think it is really sort of visually good to see. And I think it's really encouraging to see the effort that we as an organisation and our partners across the city, our statutory and voluntary sector partners, did, and how we moved things to mobilise services really quickly. If I can connect it with the opening video from Shahida in terms of Faith Star, I think there is something about, and I had the privilege about 3 weeks ago to join the group that Lucy spoke about, where we have 30 community groups that come together every week and are desperate and really willing to share their experience of what they've done. And I think there's something as a city we should think about sponsoring or doing with those groups around, if we feel we mobilised really quickly in light of COVID, those community groups acted quicker, nimbler, faster, slicker than we did. And I think there is something about, they will all have their experiences. And I think it'd be really valuable for us as a city to learn from some of that and capture some of that learning as well through those groups, to be able to, you know, we can produce glossy infographics, as Sheffield Teaching Hospital can, the Children's, and we can put it all on social media. But there's something much more powerful about those 3,000 voluntary sector groups, Mandy, that you've spoken about, or those 30 community leaders that come together every week, and actually capture some of that in our learning and in our thinking as well, and how we, if we are serious about listening, capture some of that and then learn about how we can adapt and encourage our services to be able to do something similar.
Thank you, Brian. Mark Gamsu, please.
Yeah, thank you. Two things. Sorry, I realised that I didn't say who I was, but I'm one of the lay members on the governing body. A couple of things. Like a number of people have already responded, I think having this information here is really helpful, and the way they're presented as infographics feels really strong. What I would ask for, though, is the next time that we do this, it would be really helpful, and it may not be possible with all of the information, if we could get a feeling for the impact it was making as a whole. So, you know, the proportion. So one of the things, you know, the government has been really good at pumping out information and always uses, they can talk about millions, but it all sounds very impressive. But when you actually start breaking it down, you realise that they've really not done as much as they're claiming. So I just think here for us, it would be good if, for example, you know, when we talk about the number of people, care staff who we've tested, what's the scale of our challenge? that we're facing here. And we may not be able to be completely accurate for the reasons that Lucy said, that some of the people that we're offering testing to, you know, are in the voluntary community sector. But some sort of feeling about how we're responding in terms of the scale of the challenge we have, I think is useful for us, but is also useful for the public to see, so that they can see. I mean, you know, I think I may be being unfair, but I remember at one point some national statistics were released about items of PPE, and then it turned out that the government was counting every glove issued as an item. I'm sure we wouldn't be doing that, but I think, again, just some sort of feeling of scale, or, you know, how does that reflect demand, you know, that we're getting, and that sort of thing. So I think I welcome this, but I think also it'd be great if we could move to a position where we're giving people a bit more information. Just given that this is the, I could mention this under the next item, but again, first, declare it as my second point. One of my other conflicts of interest is as chair of Citizens Advice Sheffield, and I have been using items like this as just as an opportunity to flag up. Now, with most, and because this relates to issues of financial insecurity that were being mentioned by the speaker and are referenced, I think in the next item actually, but we're seeing, we've never seen a higher demand. And national citizens, so we're now helping more people than we've ever helped in terms of demand. And with the government releasing things, restrictions on landlords chasing people for debt, for example, we're expecting that to increase. And the national message is, from Citizens Advice nationally, is to expect a 40% increase on demand from where we are now. You know, clearly that has an impact, and Steve Thomas's here is it will have an impact on people's mental well-being. So I think, you know, I'm just saying we really need to be cited on that. I think things are going to be really quite challenging for a lot of people in the city.
Thank you, Mark. Judy Robinson, please.
Yeah, a couple of points. And this one could be in either F, G or H, but anyway, I'll put it in here. Something about CHC. We're getting feedback that people who were discharged to care homes who had their treatment free are now going, the charging regime will change, and that they perhaps don't have the full amount of information about that. So I think there's a question about communication around that. I've had a quick look on the website and couldn't see anything. I think Healthwatch has been asking about that. So that's a very particular point about a specific group of people who may be affected quite soon with a change in that regime. So that's the first one. The other one that's slightly different, and responding to Brian, I mean, I absolutely agree about capturing learning and community groups. But this isn't new. This learning's been around a long time. And I would really urge that the CCG has a strategic approach that looks across the piece at where that learning is and where the resources are needed. And I think that needs to be with some of the people like Manor and Castle and so on, to really identify where short resources can be placed to most effect.
Thank you, Judy. Nikki Normington, please.
Hi, thanks, Terry. Just really quickly, these comments are not rather than questions. The first one is I really like the infographic, but I really don't think it tells the whole story about how much work went on to actually get there. Being in the midst of it all, the amount of work that went in across the CCG was unbelievable, really. I don't think we could get that down in pictures. But secondly, as well, I think is that I really like the infographic, but is this something around accepting that we also made mistakes in the first few weeks and months? We were really reactive, which is understandable. I know as a practice manager, we made mistakes in the first few weeks as we're reacting to certain situations. So I think there's something around learning from the first, which I know that's a piece of work that's going on. And then thirdly, just put everyone's mind at rest that the information is definitely out there to patients, that GP surgeries are open, because footfalls increased at my practice by 30–40%, and speaking to some of my other practices in the north of Sheffield. Sorry, I'm a locality manager north of Sheffield, apologies. their numbers have increased as well, specifically and around the sort of area with the high BAME communities as well, who probably struggled to get in through the pandemic. And so I think they're really struggling, but the footfall's definitely increased.
Okay, thank you, Nikki. I'll echo that. I've spoken with several GP colleagues across the city this week, and the collective feeling amongst everybody is actually this week has probably been the busiest week of the year, and you know, certainly workloads are picking up. That may not be the same everywhere, but certainly, you know, footfall is increasing. And additionally, telephone contacts, video consultations are increasing as well. So I shall bring us back to the infographic and the report though. So are there any further questions? Jackie?
Sorry, I just wanted to pick up Judy's question around CHC. So in the letter that we received from NHS England and Improvement, that signalled that the temporary arrangements that have been in place since the end of March for patients that normally would be assessed for whether they need to contribute towards their care. So they're due to come to an end at the end of September. So we received that information last Friday. So we recognise we do need to communicate with those people, and there is a process in train to do so.
Thank you for clarifying that.
Sorry, Tay, if I can add about that. We did produce a patient leaflet that was given to patients on discharge, and all families have been communicated with by the CHC team, but we do realise that we need to do more, because it's not enough just to communicate with them once or twice. It's, yeah, so we're working on it. Thank you.
Thank you. Mandy Forrest, please.
Yeah, to pick up that last comment, we had a long chat about this, Judy, at the Quality Assurance Committee last week, where Trish was. And that was on Thursday, so the final guidance hadn't come out from the department at that point. And we did talk about making sure that families had full communication of what's happening, and the challenges of reviewing hundreds of patients over the next 6 or 7 weeks, and the worries that will bring. So it had a thorough discussion at the Quality Assurance Committee.
Again, thank you, Mandy, for providing some clarity on that one. I'm sure it's going to be an item that will generate more discussion through Quality Assurance Committee, through our joint commissioning arrangements with the local authority, and also in governing body in the coming months. So we will endeavour to obviously keep our people in Sheffield updated on this, but we will try and keep you updated on it as well, Judy. Okay, so governing body was asked to note and consider the progress and the response to the pandemic. I think we've had a good, robust conversation there. There were a few specifics about whether the data there could be provided so we could see in the whole what was the proportional response. And Lucy, if you could note those points and perhaps pick those up with members of governing body outside, so that our next report comes back and hopefully addresses some of those points, that would be very helpful. Item number 12, paper G on the agenda. So this is the equality impacts of COVID-19 and the mitigation. So back over to Lucy, please.
Yeah, thank you, Chair. This paper really is in sort of 2 parts, but I'll introduce it sort of in the context and just take you through some of the highlights. So since April, early April, my team and the equality team have worked really hard in reaching out to the voluntary community sector to basically hear the views of the people of Sheffield, to really monitor and understand the impacts that COVID and lockdown was having on key communities, and particularly those communities within the 9 protected characteristics. So thinking about it from an equality perspective. So we've collected insights from the 3rd sector, which are logged and which has been shared with you. And alongside this, we've actually logged all the decisions we've made as an organisation, so our command and control structures have made. And we've gone through those, we've considered the impacts, both positive and adverse impacts. And we've put actions in place to reduce any adverse impacts. And that's all shown in Appendix 1 So I think there was something like 64 decisions that command and control structures made. It's not all decisions, it's just those that would potentially have an equality impact. And I think there were 4 or 3 decisions combined where if the service change continues for 6 months or longer, we'll have a legal duty to meet our duty to involve and then possibly consult on what the future service model might look like and what those impacts would be. So that list, and those areas are the hubs, so the out of hours primary care hubs, the minor injuries unit, which was closed right at the start of April. So STH could redeploy their staff to where they were more clinically needed, and also the closure of some GP branch sites, and some of the branch sites do remain closed and there isn't a plan as yet to reopen them. So those are services where we have a legal and moral responsibility to do a bit of a more detailed piece of work and potentially consult with the people of Sheffield. And so that log has been reviewed by SMT, and it's here today for governing body for assurance. And so you can consider and know all the work that the organisation has done. Terry, is that a good point for me to take questions on the decisions log, or shall I move on to the insights summary and take just questions at the end?
I think it would probably be helpful if you did sort of break the report up into those sections. So do members of governing body have any questions so far? Okay, so that's made it easy for you, Lucy. On to the next part of the report, please.
The insight summary, and this really picks up a lot of the things that Shahida mentioned in her video. And I think for me, what this part of the report highlights is that those people that live in deprived communities, those people that have, suffer with health inequalities, actually have been massively affected by COVID and disproportionately affected. So things that we've always known, but I think this report really highlights and brings to life really what people's experiences have been during COVID. So my team's spoken to 65 community and voluntary groups, and not just once. So they ring round quite a lot to get the updates and keep in touch. And there's a full log of what people have told us, which is attached in your paper, and it's updated weekly. And I think today I thought it'd be quite useful if I take you through some of the high level themes. So the overall themes are that people have told us, and this wasn't just from the early days of lockdown, it's still happening now to some extent, is that people haven't been accessing health services when they needed them. And this is for 2 reasons. I think this is primarily at the start of the pandemic and lockdown, is that they thought services were closed. But we can all remember, the government messages were stay at home, stay away, protect the NHS. And we've slowly tried to change that and encourage people to come back. But people have told us, and particularly the BAME community, that actually they've stayed away because they're worried they'll catch COVID if they did enter NHS premises. And for mental health, I think as Shahida said, that people's mental health has been deteriorating in lockdown across all groups. And one of the reasons for that is the financial impact that COVID's had and the loss of income. Lots of people have been furloughed, lots of people that work in the gig economy, they've just lost their jobs overnight. So actually their source of income has vanished. And the impact of shielding, and particularly how it's announced and how it was implemented, all of a sudden that people who thought they were quite healthy were told to stay indoors. A lot of people were fearful of mixing with anybody in their family. They had to self-isolate from people in the family. And that really has affected people's mental health. And carers have also told us they're starting to struggle, and particularly because they have no access to respite, which was available before COVID. On a positive, telephone triage by GP surgeries has been welcomed by most groups, not by the deaf community, but by all of the groups in protected characteristics. And the reason for that is because it's actually improved access to GPs or a practice nurse, that most people can actually get an appointment on the day. Other big issues which aren't particularly health related, but I thought it would be really important to highlight the digital exclusion. And that's not just for older people, that's affected people all over the city in all ages. And there are a couple of reasons. There are people because they might lack access to equipment, and there are some families that don't have any, and some families they might just have one laptop or one smartphone to share. And other people just don't have the skills to use digital equipment. And I think ONS project that up to 12% of the population do not have the basic skills to use digital services. Food poverty is a big issue, and access to culturally appropriate food. And also funding for small community groups. And this was a big theme from BAME communities who felt that a lot of the funding was going to the big anchor organisations and wasn't filtering down to the small community groups that are doing sort of the education and engagement on the ground. And if we look at the themes by protected characteristic, so BAME, big issue is a rise in mental health issues. And as Shahida talked about great length, and I think for longer than was included in the video, is the impact the loss is having, and actually the culturally inappropriate burials, and not just burials, but the opportunity to actually celebrate somebody's life and to mark their death. And that's really starting to take a toll on people's mental health, and the lack of access to culturally available support, and the fact that people have told us that they're not really accessing mental health services. And there is an increase in reported attempted suicides within the BAME community. And for women in the LGBT community, people have told us it's been a rise in domestic violence. And for the LGBT community, it's often because for financial reasons, people have moved back in with maybe siblings or their family or their parents. And actually they're finding it really tough, and their family members are being violent towards them. And the deaf community, they've told us about poor access to GP services as a move to telephone consultations. And the statistics back this up actually for the BSL service that we commission as a CCG, interpretations have gone down 90% in this period. They've also told us they feel further isolated by social distancing from their hearing family and friends, and also impacted by PPE when they use services because the masks prevent lip reading. And finally, for age protected characteristic, the impact of school closures is having on young people's mental health. They've lost a social circle, maybe they're not able to carry on with the schoolwork due to digital exclusion. Older people have told us that they're isolated because they're digitally excluded. And also young people who often got respite from the caring responsibilities and going to school, they don't have that anymore. So, and that's really impacting on their mental health. So next step, so where we were going with this. So the decision log has been to SMT, and an approach has been agreed by Speak, and also governing body back in June, that we would commission some market research with a statistically reliable sample of the population. And we've commissioned a sample of 1,000, which is statistically reliable at plus or minus 3%. And it's a sample size that Mori polls use. So it is very robust. And the survey will ask people about the 4 decisions that we need to cover around substantial change. And we'll also ask questions around the services that, or the beneficial changes we need to lock in, such as virtual appointments and telephone appointments, and generally just the changes that will remain part of the new normal. So this will go some way to meeting our legal duties, but extra engagement might be needed. So I'm going to work up a more detailed paper and take it to senior management team this month and to Speak on the 1st of April, just so we're assured that we are meeting our legal duties, and if there's anything else we need to do, we will do it. And I'll bring that information back to governing body for information. And in terms of the public insights, that work is going to continue for the foreseeable future, but we're going to move to fortnightly reporting, and we share that widely internally and also with equality leads across the city, and also ACP and people like Shahida. And we're going to go through the feedback line by line, taking action where quick actions can be taken. And for the other actions that require something the more transformational or where funding is required, we're going to build that into our commissioning intentions work. And actually the commissioning managers in SMT met last week to have a conversation and to talk about what we can do to reduce these disadvantages. So that work is ongoing, and so it will be a key part of the Commission intentions work. So just to sum up really, governing body is asked to note the work that's been carried out and the work that the CCG has done to reduce impacts where possible, and also to agree that we've shown due regard to our quality duties during this time. So really the question there is, are you assured that we've done everything that we can do to mitigate and reduce any disadvantages? So I'm happy to take any questions.
Thank you, Lucy. So Mark Gamsu, please.
Yeah, thank you. I'm not going to comment. I mean, there's a wealth of information in there, and I'm sort of sitting there, and I don't know about other people, and but I don't know if anyone finds it a bit weird that our head of communications is giving us this sort of view about what's going on in the city, and reflecting back on. I know that you're responsible for equalities as well, Lucy, but then finding that a bit weird, because it's certainly not what would have happened a few years ago. And actually, I think what we're hearing and the work that Lucy and her team have done with others and the relationships they have with Healthwatch and VCS and so on. And I know I've said this before when we've heard this, but this is really powerful. This is about, and I think for us, and I'm pleased to hear you're going to continue with it, but this should be a constant challenge to us, because the tradition in the NHS and in other statutory organisations is, oh, well, we think we know what some problems are, and we're now going to go ahead and plan it and then consult. And what we're getting here is the voices coming in from a range of individuals and community organisations and the voluntary sector and others, saying these are the things we're worried about. And this is a shifting in terms of how we approach things. And frankly, if any commissioner sitting in this meeting, listening to that, what we're hearing is a goldmine of issues that relate to their, there'll be some that relate specifically to them that go, oh, that's great, we take that and we can use that in terms of moving forward, in terms of changing what we do. So I think this is a huge sort of validation of place-based working. Of course, it's not perfect, and there'll be things we can criticize about it. But this I think is an indication of how we should continue to be working in the future, post-COVID, hopefully at some point, because it's a complete rebalancing. It's a challenge to us about it. And the last thing I'd say is, I think it's what we see also is it's built on the hard work and relationships that the communications engagement team, but others in the CCG have done as well, so that people trust us to be engaging with us and actually providing us with that information. Okay, end of advert, that's it. Thank
you, Mark. Leigh Sorsbie, please.
Again, agreeing with Mark, again. Just to say, yeah, it does feel really, really encouraging and really helpful to have all this wealth of information. And I suppose my reflections on it are a concern, an area of hope, and then another concern. So my concern is the overriding message from all of that was concerns about people's mental health. Across all sectors, that seemed to be the loudest message that I could hear. So that is an area of concern, because we've discussed previously about the strain and the increased demand that already pre-existed within the mental health services, and we have got to be very, very mindful of that going forward and think about what the impact of COVID now means on a service that was already overstretched, because it sounds to me as if it's going to be even further stretched. Mandate from the public to be prioritising mental health services, which I think is quite a helpful message to receive. My bit of encouragement within that is actually traditionally some of the hardest groups to reach are the ones who are talking most about their mental health concerns. So again, that for me is a sign of hope that actually we may be able to start to address those needs in a much more effective way. My only other concern, well, lots, but my other main concern with this is there didn't seem to be anybody saying, oh, I'm really worried that I haven't been able to get my blood pressure checked, or I haven't had my long-term condition review. And so there's all that preventative work, which perhaps isn't high on the general population's radar, that we clinically know is really, really important and crucial to long-term health. So we just, again, have to be mindful of that as well, that that's a real area of concern. It may be that people have had their long-term conditions, because I know we've had lots of innovative ways of doing it, and there's been lots of home BP monitoring and remote consulting, which has been really helpful. But that is a really significant area of clinical concern, which I didn't hear reflected back from the public.
Thank you, Leigh. David Warwicker, please.
Hi, David Warwicker, Deputy Body GP from North Sheffield. I was surprised that there wasn't anything about death from COVID. You know, like under the BAME heading or the age heading. You know, like the stuff about mental health stuff. And of course, that's important. But I think that some of the statistics we've been getting about, I mean, in our sort of statement on our stance on attacking racism and inequalities, we mentioned that the risk of dying of COVID-19 is higher among BAME people, and that all deaths of BAME people during the COVID crisis has gone up relative to white people. And I'm surprised that that's not one of the main themes here. So that was interesting to me.
Thank you, David. Judy Robinson.
Yeah, a few points. A number of us here last week ago were talking about the health and wellbeing strategy, the city strategy, which covers very similar points. So I think a reference into that and some coordination would be really helpful. So we're pulling all our resources together. And in a similar way, I really wanted to ask, because I know at least 3 surveys going on about people's experience. If you're not careful, you could be asked by endless researchers about all sorts of things. So again, there's something about coordinating and using all that material. But lastly, in a slightly different area, Health Watch has spent quite a lot of time over at least the last couple of years working with the deaf community. We've had very little support around that and very little positive response. So what worries me is that things pop up in crises, but because we haven't got a strategic partnership, we aren't looking across the piece, and we respond in a rather less than planned way to those immediate things. So I would really ask for thinking about that strategic partnership with voluntary community organisations and Health Watch and others, so that we're not taking the latest thing that's on the top of the agenda, because some stuff there are huge blind spots about, and we really need to not lose those. And the deaf community is a good case study of that. It's suddenly in the news. It wasn't before, but the issues were just the same.
Thank you, Judy. Final comment, please, from Steve Thomas.
Hi, everyone. Steve Thomas, GP and Clinical Director at Sheffield CCG. Just picking directly up on Judy's point, sort of absolutely, sort of we can be surveyed out, but one of the things that I wanted to appraise colleagues of, and many of you will know already, is that there are a suite of rapid impact assessments that are occurring across the city. This dovetails, beautifully, really, sort of with what Lucy has articulated in the paper earlier on. And there's no surprises here. Sort of, but we are not surprised, and maybe shouldn't even be surprised, that COVID has actually been sort of that great revealer and confirmer of substantial and significant health inequalities. But the rapid impact assessments are covering mental health, alcohol, substance misuse, poverty, housing, adverse childhood experiences, domestic violence. And I think that some of the key things, and it's like anything else, when we look at things from lots of different sort of perspectives, sometimes we don't get the overarching sort of picture. And that's why it's really important to have multiple views. But it's really more fundamentally important for those multiple views to become cohesive. So adverse childhood experiences are going to have long-term consequences for us, notwithstanding sort of Leigh's highlighting of mental health problems. Looked after children placements, you know, sort of being challenged and breaking down. And actually coming back to Mark's point right at the beginning, is that this goes well beyond health and the NHS. This is and needs to be us working collaboratively across health and social care. Debt and economic consequences of unemployment and the potential sort of unemployment coming out as being sort of some of the substantial high impact issues on the mental health, the rapid impact assessment. And we're looking at the potential possibility of an increase of maybe 40%. And that's really conservative estimations of mental illness problems being referred into sort of NHS services. That for us as a city would be something like 1,400 to 1,800 additional new mental health referrals into IAPT or secondary care sort of mental health services, not just what general practice and primary care will deal with in terms of mental illness, morbidity. Having said that, colleagues, you know, we have a new framework that is being tested, you know, in 4 primary care networks at the moment. And in the 5 weeks of this being launched, and was launched in the context of COVID, nearly 200 people have been identified who would have neither have met the criteria for secondary care mental health input, or really been appropriate, too complex for IAPT. And of those 200 people sort of have been revealed with unmet needs, nearly 45% of them are from BAME communities. And that's just happened in the last 4 to 5 weeks in our health and social care economy.
Okay, thank you, Steve, for that update on the transformation work that's been undergoing, and also the importance of those health impact assessments that are being undertaken in Sheffield. So I'm going to move us on to the final part of this paper, which was broadly 2 questions for us. One of them was to note the work carried out so far, which I think from the conversations we have noted that and discussed that. But the second point here was an assurance point. So this is for governing body to agree that we have shown due regard to our equality duties during this time. So if I can ask members of governing body again to raise their hands if they agree we have shown due regard, particularly noting the nuances that were discussed with the questions and discussion with Lucy there. Okay, thank you. So I'm going to move us on now to item 13, which is paper H, which is the communications and engagement update, and back over to Lucy Ettridge once again.
Thanks, Chair. Before I present this paper, I can say I do have the answers to some of Judy's concerns, and I will be able to reassure her, but I'll email you about it. We have coordinated, and we're doing lots with the deaf community, but I'll email you separately.
Thank you.
Just let me get my report up. Got too many open. You'll be pleased to know I'll be brief, because I think you're probably sick of the sound of my voice. Just firstly start with an apology due to the pandemic and not holding governing body meetings during the spring, that our board paper's slightly out of sync. I like to bring it every 4 months so you get through a year, but this covers a slightly longer period. And during this time, the team have been really busy on internal comms, stakeholder comms, and also PR. In this period, the positive coverage has gone up, and actually the increase in our broadcast media coverage has gone up, which just is more prominent. So it means that actually the good work of the CCG would have been, and our partners would have been seen by more people. Aside from the sort of media and external facing, before COVID, we spent a lot of time working on the urgent care campaign. Unfortunately, we weren't able to evaluate it because we had to stop it a few weeks early because of the COVID pandemic. and then now aren't really in a position to do the thorough evaluation. So we're just rethinking what we need to do there, because obviously we want to learn from it and we want to know the impact that it had. Our social media reach has gone up massively during this period, so hopefully you'll see that up 200 to 400%. And actually we've increased the amount of content and what we post on social media. It's become our primary communication channel. As a side, internal engagement, we've done a lot on equality. We've done a lot of engagement with staff. There's lots of networks that have been created. We've set up a corporate equalities group, which is in the early days, and it's looking at how we respond to COVID, and also it's been considering Black Lives Matter. We don't have all the answers yet, but the idea is that we'll use the group and embed it within our structures and governance within the CCG. So the equalities group, which will be members are enthusiasts, and then some people are there because of the role, you know, for example, HR and staff side and equalities, but everybody there is really committed in improving the lives of staff and improving the lives of Sheffield people. So hopefully I'll be able to bring more information on what that looks like and the impact it's having in the next month or so. And we've had a Black Lives Matter fika, which went down really well. I think we had about 66 people, and there's another one next week. If you haven't got invites, I will send them out because it was a really good event. And just one other thing to finish with, before COVID, we submitted the engagement evidence for the oversight framework, which has replaced IAFT. And last year, engagement and experience got a good rating. And actually from the evidence that was submitted this year, we think and we hope that we'll get an outstanding rating. I don't know when the information's out. It's normally out in July, so I'm assuming that's been delayed. And in terms of the next 4 months, it's an unusual position because we've just come out of the command and control and we're not quite settled into our plan yet for business as usual. But we're doing a big piece of work on the commissioning intentions, engagement, and making sure that they are public friendly. And we're going to go massive on a flu campaign this year. Obviously, we all know about the targets that the government have set. And from our engagement, we're hearing that actually the BAME community are really nervous about vaccinations. There's lots of people are worried that they're being experimented on around COVID. And I think we've really got to think quite carefully about how we engage the BAME population and other populations, and also continue our COVID engagement and our communications around warming and informing. I think people are getting sort of desensitized now to a lot of the information. So we're going to launch a sort of back to basics campaign, really getting people to wash their hands, cover their mouths, and just adhere to guidance. And we're just going to think of a different way to do that. So I'm happy to take any questions.
Okay, thank you, Lucy. So I'll open up to questions. I think governing body are fatigued with questions, Lucy, and nothing coming up there. So governing body is being asked to consider and note the work undertaken and its impact and raise any questions. I can't see any questions coming forward. Lucy, I'm particularly encouraged with the hope and expectation that we may be rated outstanding for our communications and engagement. And I think reflecting back on some of the points Mark had made earlier, about a year ago, we might not have been having the conversations about that in-depth level of engagement that we had undertaken. And certainly the types of conversation we are having here at governing body are perhaps quite different to where we were a year ago in terms of that insight that we have into the populations that we look after and the communities we work with. So I'm hopeful that we will get that outstanding rating. And even if we don't, I'm quite keen that we recognise the outstanding progress that we have made compared to last year. So thank you and well done for all of that work. And whilst I've been talking, a hand has gone up. So Mandy Forrest, please.
Sorry, I was just a bit slow putting my hand up. Can I just check? There's been, I think the Director of Public Health is putting out a communication to every household. Are we involved in that to get across some of the simple messages as well?
I wasn't aware that Greg had an individual message, but I know the council send out a weekly email and got opportunities to put things in there. Yeah,
right. I think this is
because there's close
yeah, I think this is a leaflet to every household, not just the weekly messages. I've seen it, but somewhere else. But I haven't read it.
Mandy, the leaflet has been delivered. I received mine on Monday morning through the post. There has been engagement between all of the communication teams from various NHS, local authority and voluntary sector organisations through the citywide health and care gold in working up those messages and those communications. Brian, I can see your hand has gone up there. Did you want to add to that?
It's just exactly what you said, Terry. Thank you.
Okay, thank you. So hopefully that gives some assurance, Mandy. So in the absence of any further questions, I will move us on to the next item of the agenda. So item 14, paper I, which is the month 3 finance report. So over to Jackie Mills, please.
Okay, thank you, Terry. So as we've trailed, there are some key points in this paper, so I do want to take some time to take you through it. So the paper outlines the changes to the financial framework that were in place for the period April to July that were implemented as a result of the COVID crisis. We have had confirmation at the end of last week that these arrangements will be extended to cover August and September. And where we go after that, I'll come on later in the paper. The paper notes that the nationally calculated allocation that we have been given for these 4 months, we've compared that to what we would have expected to receive based on our previous plans, adjusted for our estimates of the impact of the changes to the financial framework. And you'll see in the paper that we've estimated that on our calculation that the allocation given to us is about £1.6 million lower than what we would have calculated ourselves. And I think, David, when we discussed this at the last meeting, it was one of the questions that you posed to me. So we have now quantified the difference between the allocation we've received and what we would expect to receive based on our plans. In terms of the financial framework, as Mandy alluded to earlier, we had expectation that retrospective adjustments would be made to the allocation for appropriately approved COVID costs. And we've talked previously about a national programme to audit those. And in addition to that, where we can demonstrate there are legitimate reasons why our spend is higher than that nationally calculated allocation. The indications from NHS England were that retrospective adjustments would be made to the allocation. Just to note that to date, so up to the end of July, we've only received 1 adjustment to our allocation, and that is just for 2 months worth of COVID spend. So there's a level of COVID spend that we are reporting that we've not yet had a retrospective allocation adjustment for, and there's been no top-ups approved for the variance from the allocation that's non-COVID related. So the expectation we still have is that those adjustments will be forthcoming, but at this point I can't give you a timescale for when they will be actioned. Then moving on in terms of the monitoring that we have against the revised allocations, we're forecasting that by the end of July, and we haven't yet closed down the full July position, but we're forecasting that by the end of July, there will be a £7.8 million adverse variance. Of that variance, 4.8 million relates to COVID costs that have not yet been reimbursed. 1.6 million is due to our calculation that we believe the allocation was calculated incorrectly. And then the remaining 1.4 million relates to true variances from our original planning assumptions. And that's mainly in relation to our prescribing spend. Governing body members may remember that when we reported the position last month, though, we had got confirmation of our final prescribing spend, and we saw March spend was a lot higher than we'd allowed for in our accounts. So £500,000 of the adverse variance in terms of prescribing relates to the additional March spend. We had anticipated that that may be due to more people before lockdown accessing prescriptions. However, the volume and the costs were equally as high through April. So we forecast forward based on the April's position. Since the report was sent, we have had the May's prescribing position that has come down slightly, but does not bring us anywhere near to what we were planning on when we set the budget originally. We've now, as I noted, we've now had the planning letter from NHS England Improvement that sets out the key priorities for the remainder of the financial year. And I'm sure we'll cover that in more detail. In terms of the financial framework for the period October to March, that now confirms that we will continue to have block arrangements in place with the providers. So they will be the nationally calculated block arrangements. There will be no reverting to the previous system of having payment by results. There will be allocations that are then allocated to the ICS, so in our case, South Yorkshire and Basset Law ICS, and they will be responsible for allocating that funding to the organisations in South Yorkshire and Basset Law, both to cover the remaining COVID costs over the rest of the financial year, but also to fund additional costs that are already in the system and additional costs that are required to meet the priorities as set out in the NHS England letter. It is important to note that in that arrangement, it talks about block arrangements with trusts will be, the phrase is meaningfully adjusted for performance. So some expectation that performance will be either better performance will be rewarded, or potentially performance will, if people that don't reach the performance targets expected may be penalised. So there's a significant amount of work to understand over the remaining months of the financial year. The funding that may be available to the system, what the priorities are that we agree across the system in terms of what that will fund, and then importantly for the CCG, what that then means for us in terms of meeting the key priorities for the remainder of the financial year. So it links very clearly back to the discussion that we had under the governing body assurance framework about how much progress that's likely to allow us to make in terms of our strategic priorities. Just one specific I would pull out in that, because we've touched on it earlier, and that's around mental health. So clearly we had a large aspiration for further investment in mental health services. The national letter does confirm that we should continue to plan to meet our mental health investment standards, and yet it still continues to say that they're going to issue further guidance to us on what that really means and the funding that may be available for that. So there's still a significant amount of uncertainty and additional guidance that we are expecting to receive that will help us answer some of those questions. So I think they were the key points that I wanted to pull out from the paper, but I recognise there's quite a lot of information there, so I'm happy to take any questions.
Thank you, Jackie. So any questions, please? Nikki Bates.
Sorry, can I ask probably a daft question, really? So with the block contracts, if the hospitals do an awful lot of work to catch up on the stuff that they should have done but haven't been able to do due to the COVID crisis, will that be funded centrally through the government, or will we have to pay more for that increase in activity?
So it's not a silly question at all, because it's one of the main things we're wrestling with. We're anticipating that the funding that comes into the South Yorkshire and Basset Law ICS will include funding that covers that increasing activity. So all the providers at the moment are being asked to submit plans in terms of what they can do from their existing capacity and what it would take to increase their activity. So that's one of the things that will be a draw on the system resourcing. But equally, I should point out that would also cover things like mental health investment standards, the work we might want to do around tackling health inequalities will all be competing for the same pot of money. So it's those relative priorities we need to work through.
you. Leigh Sorsbie, please.
Thanks, Jackie, for this. I know that was a tough presentation and it was quite hard to listen as well. And thank you for all the work you and your team are doing on this. One question is around the prescribing, and I just don't wonder whether it's a discussion for here or whether I need to talk to you later on, because I just would be quite interested to understand the mechanics behind that increased prescription cost, given that actually activity was very unusual in March and April. Obviously there was a lot of COVID related activity, but a lot less of routine work. And so I don't understand whether that increase in cost is because of increased number of prescriptions or increased cost of prescriptions, and how much relates to COVID and how much relates to a different way of practice. And the reason it's important is if it's a result of one of the spin-offs and the possibly unwanted and unwarranted spin-offs from remote consulting, we need to understand that if we're thinking about what the future is looking like in a living with COVID world. So that was one slightly long question that I may need to get the answer elsewhere. And the other question again is related to Nikki's point about trying to understand how the block contract worked. So, and how it was set. So was it set reflecting historical activity, which then didn't happen during COVID, and therefore will there be that sort of, will the effective overspend that's been given for an underactivity be reflected going forward in that overactivity with, you know, not matched by increased spend or not?
Okay. So I can answer those two questions. So the prescribing data we have says that it's both volume of prescription, volume of items, as well as the cost of the average cost per item. So on page, I don't know what page it is, page 7 of this report, we talk about 3% increase in average price and 6% increase in volume. I think the important point you raise though is understanding what the reasons for that and whether they're long-term or short-term impacts. And it's too early to make a judgment on that. In terms of the block contract, it was based on historic spend, so not historic activity, but historic spend. So largely the number of staff that providers will employ and their historic infrastructure. So you could argue that activity was low, well, elective activity particularly was low over April and May, but they should be able to do more within existing capacity, bearing in mind the reduction in productivity related to social distancing and PPE. So that's the plans that the provider's being asked to submit at the moment. And it's fair to say that the initial plans did show a significant level of variation between providers about what they thought they could deliver within existing capacity. So it's all to do with historic spend, not historic activity in the blocks. And that's what it was all a national calculation, and my provider colleagues will explain in great detail why those, like I've explained for the CCG, why those calculations maybe weren't accurate.
Yeah. Okay, thank you. I'll email you later because I think I feel like I need a little bit more. I still don't fully understand how that's all going to work. And part of me thinks, well, it's set and there we are. But another part of me thinks, well, actually, this is really, really important because I don't remember having a black square on our risk framework. And so I think we do need to understand what this means going forward and what room there is for redress or variation or appeal in this, because I don't understand it yet.
Okay, thanks, Leigh. I think you're probably not the only one that is finding the financial framework somewhat confusing. And I'm wondering, Jackie, just as it becomes a little bit clearer, Leigh's offered to try and seek some clarity through email, but I'm wondering whether a small masterclass for governing body might be helpful once there is some clarity on that. So would that be something you would be able to do for us, Jackie?
Yeah, definitely. Once I've put it out for myself.
Perfect. I can see lots of heads nodding away there and thumbs going up. So I think a deeper understanding of some of those new and complex ways of funding would be appreciated across the governing body. Are there any further questions for Jackie? Okay, so Lesley.
It isn't a question for Jackie as such, but in relation to the masterclass, I think it's a bit of a plea, because I think I found myself at governing body where on the one hand we're saying we've reached a point where we've got terrific insight into challenges and issues in our local population. And we're almost on the cusp of what are the things we can do differently and with our strategic partnerships. And I think that's huge to us going forward. But at the same time, this is also the governing body in which actually we don't have an allocation as it stands at the moment. And that's the core of this. So our ability to flex and use our resource differently is stymied. So in our masterclass, I think we need to, and we probably have to have quite a few, and they might be workshops around how we work creatively and innovatively and with who to steer our way out of the position that we're in at the moment in the best interests of local people.
Thank you, Lesley. I think it is a very interesting point, because one perspective we could take is that if organisations are receiving block contracts, then there's little we may be able to do as a commissioner to affect things in a different way. An alternative perspective would be to look at that as an opportunity to encourage our system partners to begin to work together in a different way within their financial envelopes to mutually cooperate with one another for better outcomes. So I think that would be a very helpful addition to that masterclass, and certainly considering our role within the wider partnership of our accountable care partnership in Sheffield, it could be a very important strategic type of discussion for us to have. So I suspect we will probably need some broader support as well, so poor Jackie doesn't have to shoulder the entire preparation of the masterclass there, and I'm sure you will offer your wisdom there, Lesley, for us to tap into. Okay, so any other comments at all? So governing body has been asked to note the financial position outlined in the paper, which we have done and we have commented on. So thank you, Jackie. Next item, item 15, paper J in your packs. This is the performance and delivery report. So over to Brian Hughes, please.
Thank you, Terry. And I'm also conscious as well that I didn't introduce myself, even though I've spoken loads throughout this afternoon. Brian Hughes, I'm Deputy Accountable Officer at Sheffield CCG. So familiarity of
Brian appears to have frozen there. I understand that he's having some work done on his broadband. So whilst Brian recovers his internet position, I'll move us on to item 16, which is the patient safety, quality and experience report. And Gary Barnfield is going to introduce that for us on behalf of Alan Windle.
Sorry, struggling to unmute myself. Yeah, so this report covers the first phase of the COVID crisis and provides an overview of how the quality team responded to the challenges that presented, what effect it's had on services, and how they're now adapting again as we emerge from the first wave. I'm really hoping the report is self-explanatory, as I'm not the subject expert. But I'm happy to try and answer any questions you may have, and I may have to refer them elsewhere.
Okay, thank you, Gary. So obviously this paper has been circulated in advance and usually goes through any particular safety incidents that have occurred within the CCG area, which will also include services that we don't directly commission but are provided within the commissioning area we cover. It covers the safeguarding reports. It also covers any serious untoward incidents that have happened and matters regarding infection control, clinical audit, and any CQC reports that have come through. It importantly covers patient and staff experience from across our providers, including care homes and general practice, and finally moves on to some more specific measures concerning some of our providers. So the governing body is asked to consider and note this paper, and I'm aware that this will have also been discussed in the Quality Assurance Committee as well. So I'm just going to bring in Mandy Forrest, who is the chair of our Quality Assurance Committee, to see if there's any particular highlights from this paper that you'd like to bring in.
Not particular highlights, because we have gone through it all, but just to remind colleagues that we've moved to monthly Quality Assurance Committee because our legal duties around quality and safety haven't gone in the COVID period, and we were very concerned. There was so much going on that we needed to keep a handle on this. So I do want to thank those members of governing body who have joined in on the monthly meetings. It's been great having new people on it, and I want to thank Healthwatch, who contributed hugely to the Quality Assurance Committee and the whole team, because it's put a heck of a lot of extra work on people, but it has meant that we've been able to track issues much more rapidly and deal with them in between the monthly meetings as well. So we've managed to keep on top of those issues that are of concern, even though providers haven't had to provide information or collect information on patient experience. We feel we've had some really good ways of taking these items forward. So thanks to everybody. And I think the report is self-explanatory. I think the issues that will concern us over the next few months are continuing healthcare as we move back to the normal situation, and care homes, patient safety in care homes. So we're getting full briefings on those. So thank you, everyone.
Thank you, Mandy. Are there any comments or questions relating to this paper? Okay, so our governing body is being asked to note the information in this paper and consider any points that it wishes to make. I can't see any hands have gone up, and Mandy, I think, has given us some assurance today that these matters have been picked up through a more regular Quality Assurance Committee meeting than usual, and we can be assured as a CCG that these matters are being picked up, but also we have gone beyond the reporting requirements and legal duties placed on us under the command and control structure nationally. So I'd just like to thank Mandy and also Alan and the members of the quality team for standing up that meeting on a more regular basis, because as you say, the duty on us to have high quality services has never gone away, and I'm thankful for the work that you've done in making sure that we've kept on top of that. So thank you, Mandy and team, for that. So Brian has made it back to the meeting, so we will go back to item 15, which is the performance and delivery report. Brian, you got to your first few words before you froze, so it would probably be very helpful if you could start from the beginning for us. Thank you.
I will, and apologies for the technical loss of signal at that crucial point. So what I want to try and do, hopefully there's a familiarity with this report. What people who have tracked this, particularly through COVID, will see in this month's report is a slightly expanded set of indicators in terms of measurements that we would routinely receive and talk about as a governing body. Quite a few of those were paused during COVID. What is included within this month's report is, as we start to move and live with COVID, there are a number of indicators which unfortunately start to highlight the impact that COVID has had, particularly in those early few months in terms of activity. But it also then starts to expand into other areas. One which is a report on the impact of COVID and the numbers around COVID, and there's a suite of metrics and information contained within that, some of which was picked up earlier in terms of Greg Fell and communication that he has given both within the CCG and to the public in terms of don't make yourself a contact. And if in doubt, get yourself tested. So two key messages that as we begin to live with COVID, really strong messages from our Director of Public Health. But also what is also contained within the report is last month we talked about our improvement plan. And as we sort of concluded most of the actions in that, we agreed that we would report and continue to report on a suite of internal metrics around our organisational responsibility and our staff, both in terms of key performance metrics about sickness and turnover, but also as we've begun to work in a different way with our staff around gauging the temperature check, engaging how they are, their welfare, and their ability to work, and what we need to do as an organisation to support our staff. So the report very much breaks into three bits. There's the external performance metrics, there's the what's happening in the COVID sense, and also what are our staff feeling and what are the metrics contained around that. On the performance metrics, what you will start to see is that effect that COVID has had. So Jackie outlined a couple of minutes ago as well about the impact on planned elective performance over March and April. As we start to try and get back to operational levels, living in a COVID secure environment and providers operating in a COVID secure environment, we can start to see the impact that that has had in terms of the length of time people are waiting. And what you see in this month's report is a growth in the number of long waiters, i.e. those patients waiting over 52 weeks. That will probably continue to grow as we sort of go through the next few months. What I can reassure governing body is in terms of waiting list management, all our providers are clinically prioritising patients on any active waiting list to make sure they are treating those most in need and taking that into consideration. But there is a consequence of that in terms of some long waiters may wait longer in the coming months. Nikki mentioned earlier about primary care activity now coming back to pre-COVID levels, and Terry, you commented as our chair in terms of some areas indicating they're busier than they have been and reporting their busiest weeks. A&E numbers, again, as we've reported in previous months, those numbers are starting to increase and again are coming back to levels which we would have seen for this time of year prior to COVID. And also the performance report also indicates the impact that COVID has had on some cancer treatments and delays in cancer treatment and the recovery that will be needed in accelerating some of that activity and undertaking that either within our acute hospital providers or in a number of instances where we have secured the independent sector capacity, actually using those as COVID clear sites and maximising the cancer capacity through some of our independent sector providers. So that's the performance metrics. On the staff experience, I think it's really useful to see, and the staff temperature check, to see some of the feedback. We engage with our staff on a fortnightly basis, which a number of our governing body members join those sessions in terms of how they feel and actions that we are doing as a consequence of that to make sure that our staff continue to feel valued, connected, and able to undertake the work that they need to as an organisation. And then finally, the numbers that are reported in the third section of the report around the COVID activity shows the current position, or the position as of a couple of weeks ago, which is reflected nationally in terms of the phase and the wave that we are at. The numbers are thankfully reducing, but a lot of activity that we are undertaking within the system and within our organisation is to prepare for what might come next, and in terms of planning both for winter and for a potential re-increase or reintroduction of numbers and how we will cope as an organisation and as a system. So if that's okay, Chair, I'll pause at that point and then take any comments on any of the detail within any of the 3 sections within the report. And just to acknowledge that what we will see in future months is those 3 sections: the finance report, the performance and delivery, and there's been a conscious decoupling of performance and delivery from the quality, patient safety and experience report, but they will be seen as a suite. And apologies, Amanda, you've probably sort of updated while I've been off in terms of how we'll see each aspect of those in splendid unison over the coming months.
Thank you, Brian. So I will open up to comments and questions. So we haven't any comments or questions at the moment coming through, Brian. I'd just like to draw attention to the staff temperature check within this report, and just reflect back that probably at some point around a year to 18 months ago, governing body had received a national staff survey, and were particularly interested in trying to understand more about some of the issues, some of the good points about what it was to work at the CCG. And I think the staff temperature check gives us much more detailed insight into what's happening. And this has been particularly useful to us during COVID. I'm just wondering whether any members of governing body have any reflections on the CCG health check report, but also that staff temperature check. So I'm wondering, Leslie, whether you have any thoughts on that, or Brian, whether you have any thoughts you wanted to highlight. Or indeed Sandy, who I know has been involved in some of that work.
I think I'm happy to kick off, and then others may come in with ideas and views to help support. So I think we've only got a snapshot of the temperature check in this report, but what we do have and publish on the internet is very, very detailed, and we're doing it fortnightly now, and we can see the trends. I think on the surface of it, we've got some really good response mechanisms in place. And we started with, and this is interesting, in a request to do a we said you did. Now that's interesting culturally, isn't it? Because it's almost about who do we hold to account for the things that we don't like. So we changed that to a we felt and then we actioned. So sort of an empowering piece, which is it is within our gift to resolve some of the issues that are around us in terms of the work environment. And we've got feedback, and I wasn't at last staff brief, but you can see if you look at the temperature check, lots of people talking about how good that feedback was in terms of the actions that have been taken in response to these other things that we've actioned and done differently. But equally, we still see within there staff who will question, they can't see where the temperature check's being considered, and they can't see how the actions are being taken forward. And that's probably something of, if you live in an environment and your expectation is either you're not valued or you won't be heard, you'll always pick up on any bit of evidence that, you know, concurs with that view, rather than the things that are happening that don't. And all that means is that I think we probably just have to do more. So some of the things I've been thinking about, we considered this through the staff forum. We've been doing it through bronze, but we're stepping down our bronze command. So we probably have to think about it through our deputy directors, our executive team, and our staff meetings. And actually something about the temperature check, each fortnightly temperature check, being discussed on all of those agendas, so teams can think about how what's coming out the temperature check relates to their directorate, their team, and what they feel empowered to do and to change about that. So I think we need to put more of that in. We probably need to, and I thought maybe carve out again on a consistent basis some time at staff brief on our temperature check, put it further up the agenda. I think I've been conscious when I've been doing it, you feel sort of a bit rushed for time against some of all the other items that we've got to discuss, and whether that makes people feel we're only paying cursory attention to it. But that led me to, and I will actually just put this to the staff on Monday, if we're going to do that, it may be, and this may address some of the factors in the temperature check, that we actually move to weekly virtual staff briefings for the moment, and that would allow us to pay more attention to those things. There are some things in there that chime with a culture survey that we did last year, where really the things coming out of that we need to work on as being of a fixed mindset, focused a bit on the rule book rather than innovation and growth. So that's quite interesting. If you look at all the staff temperature check week on week, there's an issue about chairs. And actually there's a comment, so this is the chair that we sit in when we're working from home, and how we might struggle if we're not sitting in the right chair. And almost a sense of having changing rules around whether I can have my office chair at home or not. And actually there's something that I think we need to turn in its head. If you're working from home and you need the right equipment, then how do we turn things on their head to make sure that we action that swiftly?
Okay.
So there's just some reflection for us that I think when you read it, that we're looking for what's the rule or what's the rule book, rather than what are we trying to achieve through that.
Okay.
So those are my ideas, having gone through particularly the most recent one and thinking about what's changing, what's not, in terms of how we can respond differently and how we seem to be responding. But I'm happy and open for other ideas on that.
Okay, thank you, Leslie. I'd also like to just draw attention to one part of this report, which is on page 15, and this is around staff within the CCG having formed a learning group, which I think is good news in terms of staff feeling empowered. So the staff group are meeting together to discuss and relate their experiences of working through COVID and how that's affected them. And initially, I think I agree with Leslie, the discussions are along the lines of what problems do we need to highlight? And the sentiment has shifted to what are we empowered to do? And I've encouraged that discussion. And I'm really pleased actually that there are a number of very significant stories with lots of rich learning that have been shared on our internal intranet pages. And I would encourage members of governing body to take a look at those and read them. Another invitation I have extended to the group is to come to a private governing body session and to share their stories with you as part of this temperature check and part of this learning. So again, Leslie has picked up on where is this information being noted. I think it's fair to assure our staff that this is being noted by the governing body, but we are also interested in some of that learning and that community of practice our staff are forming in terms of how they wish to affect the way that they work moving forward. So please note that on future agendas, much as we have a patient story in our public agenda, we will probably be moving towards having a staff story as we move forwards into the private agenda. So I can see Sandy, you've got your hand up there. So Sandy, welcome to governing body for your first comment here. So over to you.
Thanks. Sandy Buchan, Interim Director of Commission Development. The only thing I'd like to add really is that this temperature check was developed during the COVID crisis with members of staff. So it's something that wasn't asked of staff, it was actually their comments, and they wanted to be involved in actually developing this staff temperature check to make sure that all staff members were talked about in terms of what they felt, how they were, and made sure they were able to get that across to the senior members of the organisation. But it's been that positive and it's gone down that well that actually they want to continue this, which is why it's now becoming embedded within the organisation's processes, and why we've added it into this report to very much highlight that from the ground we are able to articulate how the staff are feeling and what we're doing about it. So very much in the fact that we're listening to what people are saying, what our staff are saying, and how we are acting upon it. But as Leslie says, we are embedding it within the way we work in terms of the meetings, our team meetings, directorate meetings, and our staff briefings, in order to make sure the staff know that we are acting on what we're being told. Thank you.
Okay, thank you. Yeah. So again, I think the richness that's coming now has changed from, you said we did, to our thoughts and our actions, which is, I think it is a cultural change within our organisation, which is really pleasing to see, considering the position we were in 18 months to 2 years ago. So, and I think that is testament to the hard work of everybody who works in the CCG, and I think I would like to recognise that, and certainly I hope governing body will recognise that that's been a contribution from everybody within our organisation. Are there any further comments or thoughts on this matter? Nope. Okay, so thank you, Brian, for that paper. I'll move us on to the next section of our agenda. So part 4 is a standing item, which are oral updates regarding our integrated care system and accountable care partnership. Leslie, are there any updates for this meeting?
So I think we've probably touched on what would be the key updates in relation to the integrated care system throughout this agenda. So, and the main one being the phase 3 planning letter, and that encompassing for me what I describe as 3 R's. So the first one was restore, and we're probably quite a way through that in terms of activity. Our services rather coming back online. The second R is about recovery, and that's really a big one, and it was at the essence of part of indeed Jackie's paper and some of the earlier discussions around what we see at the moment is, because of COVID, a lot of the planned work having been paused, slowed down, or at least not happening. And therefore there's a real emphasis on, we've got a window of time between now and the winter and the flu season to act on recovery. And that's why you see some very specific targets around day cases, outpatients, elective work in that guidance. And I think we'll have a lot of focus around that in the next couple of months. And that's simply because we've got the rising tide of waiting lists and what's seen as that window of opportunity. I think those targets and that guidance really challenging to our providers in terms of meeting them. I think the current plans are probably some way short of those targets, so there's a lot of work to do. So that's the second R, and probably at the moment the most important R. And the third one is sort of reset, and some of that comes into recovery because it's around doing things differently, embedding some of the transformation that we've seen through COVID. But the other part of reset is what's the future direction of travel for integrated care systems and for integrated partnerships in place. So what's the future of system and place? And are we likely to see any legislative change coming along around that? So I think that sort of encompasses the priorities at system level. Against that background, and I mentioned this to our lay members this morning, thinking again about the governance and what refresh we have to do in relation to governance in the next few months. and also the implications of the publication of the People Plan and what that means to us both across all of South Yorkshire and Basset Law and within Sheffield.
Okay, thank you, Leslie. Any questions from governing body regarding this oral update? Okay, thank you, Leslie. I will move us on to part 5 of the meeting, which is consideration of the reports circulated in advance for noting. Does anybody have any issues, any points they want to raise on any of the noting pack? Okay, thank you. Are there any other other business, any items for any other business that haven't been notified in advance? Okay, so the last few governing bodies, we've been getting used to our technology and doing governing body in a slightly different way to usual, but I'd like to take us back to where we were pre-COVID, which is to hear some reflections on what we've heard during the governing body meeting and how that might affect what we go away and do after the meeting and what we will go away and tell people about today's governing body. So as we used to do before, if we could have 1 or 2 willing volunteers to kind of give us their reflection, and we shall take note of that and discuss that next month. So does anybody have any reflections that they would like to note from today's meeting? David.
Okay. I might be nicking one of your reflections actually, Terry, but I did write it down before I accused of nicking it. From the story we heard at the start, the idea of this nuanced approach and not just translating language, like the example of the sort of patient information leaflets and things like that, just getting translated, but actually taking into account the cultural aspect rather than just the language barrier, and being just being better at that. Especially in the face of the health inequalities that are exaggerated by COVID. Thank you.
Thank you, David. Anybody else like to share a reflection? So Leigh, please.
Again, I always seem to follow on from someone, but just in reflecting on David's point is actually, I think we could gain a lot from talking to practices who serve a lot of these populations, because I know at Firth Park we could tell you about the problems with the languages and also the problems with literacy across all populations actually, and also the challenges of cultural differences. So what we think might, from our culture might be very straightforward is actually interpreted quite differently in other cultures. So I think there's a lot to be learned. But my reflection on this meeting, I think, is really I've been struck by the conversations we've been having around feedback from the population of Sheffield and from the public, and how that's informing our decisions and our thinking, and also the feedback from our staff and how that's informing and what a high priority we now seem to be giving it, which does feel, when we have commented this as we've gone along, but it does feel very, very different. I suspect we've probably actually got a long way to go. And when we look back in a year's time, it will look even different, even more different again. But it is certainly very welcome, the distance we've travelled so far.
Okay, thank you, Leigh. I think there's something about us keeping that spirit of optimism in that vein, and making sure we do hold ourselves to account to make sure that we continue to progress on some of the good work we've had already. Amir, please.
Yeah, I think David sorry about earlier, I was having huge IT problems, so I've actually come home now from the practice. Again, taking David's point a little bit further, really, it's not just language and nuances. To drill it down even more so, what you're dealing with is 3, possibly 4 different generations within a community. And unfortunately, for the visible minorities, it's very easy to kind of have a view of the total rather than the mixture within communities. And I think we need to be really, really mindful of that. So how you deal with one generation is actually different to another generation. And the example that I gave at the CLG when the media hits with a a packed beach or a pub, that might be the center of COVID. It's one thing. When it hits with a mosque, then the whole of the community kind of feels victimized, for want of a better word, despite some of the huge sacrifices that people have made, as Shahida quite rightly pointed out. I mean, there have been several prominent deaths in Sheffield, which ordinarily would have attracted over 1,000 people at the funerals, but these people kept it down to 30, and it wasn't easy. So just to be really mindful of the more, the really nuanced stuff in all this. That's it.
Thank you, Amir. Mandy Forrest, please.
Thanks. Building on what people have said, I think what I've heard as well is we've got a fantastic opportunity to work differently and in different partnerships in the future, and particularly with the community and voluntary sector. And we just shouldn't waste that opportunity. We've talked about it for years. There's loads of evidence now of what a flexible and nimble sector it is. And there's a lot to be gained from working differently with them.
Thank you, Mandy. So my final reflections on today's meeting is, I think we've heard a lot about how we have responded to some very significant challenges over the last 6 months. And we are hearing that we have some significant challenges ahead of us in terms of rebuilding our services, resetting the ways in which we work, and understanding the financial constraints around that, but also recognizing that there has been a stark, broad light shone on some of the inequalities and the exacerbation those inequalities that we have seen through COVID. However, it does feel as though we'll probably be responding to those in a different way to how we have done in the past. Certainly some of the very rich discussions about the progress we've made with our engagement, with our communications, with our thinking about what we prioritize, and also with the partnerships that we have with other organizations, with our communities, and with our voluntary and community sector across Sheffield. I think that is a real positive, but also we do need to recognize we do have some way to go to really affect difference here. So those are my reflections on today's governing body. And again, it will be nice to hear back from people next month on those reflections and what progress and what differences we have made there. So that brings me to close today's governing body meeting. The next